Question to Professor Berg. So clinically speaking, I appreciated the algorithm on when to stop nuke therapy in patients, but often patients will do their own thing and will come back to you having stopped on their own, where the follow-up is not always pre-scheduled, and you don't know about the reliability of that patient, and often you don't even know if the patient truly had cirrhosis or no cirrhosis at the beginning of therapy, particularly in the era of non-invasive diagnosis of cirrhosis. Most patients have not had a biopsy. So when do you restart treatment in those patients, or how do you monitor those patients who have stopped on their own?
Yeah, I haven't specifically mentioned these, our monitoring strategies. We were quite careful in our finite study because we considered any significant flare with a decompensation as an end of story for all the stopping approaches. Therefore, we had every 2 weeks in the beginning, and then depending on HBV DNA and ALT increase, we have even a closer follow-up. So if there's a significant HBV DNA or ALT, we follow it by weekly basis. But from all the data we have, I think in the beginning, every 4 weeks might be okay. And after stopping tenofovir, you will see within the first 3 months what happened. With entecavir, you probably have to wait for a longer period. But I think also in preparation of this talk and looking to all this data, when you really look at severe flares, it's really intriguing that it's always preceded by this very, very rapid and marked increase in HBV DNA. So to be on the safe side, if you have 10 to the 6 to the 7, this is very unlikely that these patients will enter S loss from all the data we have. So probably it's wise to start immediately with retreatment and not waiting for a significant ALT flare. The long-term monitoring in the consolidation phase, I think it's easier because the patient is not anymore at risk. And there you can follow the patient as you do it in the beginning. If you're not sure HBV DNA is 15,000, ALT is normal, then you can judge from S level to S level whether you see any decline, it's stable, and then you make an individual decision. Yeah, please, Stephen.
Thank you very much. My question is to Thomas. Thomas, in your talk you showed a summary of possible good flare and bad flare, and how quantitative S levels could actually help clinically decide whether or not you needed to introduce salvage therapy. So are you able to give us some sort of numbers, a half a log or a 1 log change? So in the case of the good flare, the surface antigen declined by half a log or 1 log, and over what time frame, versus a bad flare where you had either no change or an increase in surface antigen, half a log or 1 log. But I mean, my question goes to the heart of the ability of the assays to discriminate between half a log and 1 log in those sort of short time frames. And how practical do you believe that to be in terms of clinical management of the flare issue?
Yeah, I mentioned the question mark in my slides. I'm not so sure whether these levels are really so helpful in the specific situation. And we have to say, because of the retrospective nature of most of these studies, we do not have S levels and HBV ALT at the same time. From what we know so far is that you can't really expect a significant drop in S levels already at this time point, but probably no increase. At least it's stable, and then you can follow and see whether there's some decline. 0.5 log is probably something you may expect, not much more. There might be some patient with a very rapid drop, but what we have observed that the S loss, the early time point we had after 1 year, and the flare were in the beginning. So it takes some time until you see that you lose S. You could not expect during the flare already a 1 log drop in S from all the data we have seen. And also in the one example from the Taiwanese group, S loss were stable when ALT peaked, but 3 years later it was undetectable, so it takes some time. But probably it's more the dynamic of ALT and HBV DNA and additionally some increase, let's say 0.5 log. But it's very difficult to give you here really good numbers because we do not have the data yet. Yeah.
But I think baseline levels of surface antigen, Thomas, correct me if I'm wrong, were they predictive of who went on to lose S in the finite studies, 25,000
I think
versus 60,000?
that's for sure. The lower the S, the higher the likelihood of losing S. but the cutoffs are very difficult to find. In the Asian studies, it's always very low, less than 100, but we do not have so often patients with such low levels. And in the Hatzianis, in our study, there were many patients even with 1,000 or 15,000, but we haven't any patient with a level above 25,000 losing S. Andre, probably to your point in all the interest in immunologic markers, I think there are two issues I'm interested in. This is timing of treatment. And we know that the immune system is influenced by the age of the patient. And we have the E status, we have the so-called immunotolerant disease. And whether you think we have to look differentially to immunologic markers in E positive, E negative, and according to age, and whether from all your knowledge there is any evidence that an earlier treatment in life could be beneficial. Recent study coming from Asia, treating immunotolerant children with a combination therapy, reaching some S losses were encouraging, but small study, first study. So what is the evidence from an immunological point of view?
It's probably one of the most difficult questions, this one, because indeed the immune system in that sense is so incredibly multifactorial that it's really difficult to answer that. But I mean, age does have an effect. I mean, also indeed the viral load levels do have an effect on how strong your immune system is, etc. So all these parameters clearly definitely have an effect indeed. But I think it's quite difficult to make a statement on indeed when you should start to treat. But I think these kind of parameters have to be taken into account in the studies that are being done.
Yeah. Are there any comparative studies in the immune function you're told with all the different cells, might, NK, and T cells, depending on age in these cohorts?
In these cohorts, no. I think Mala, can I
yeah.
think
Sorry, I forgot you, Mala. You also have a question.
I think age has not been taken into account in any of these analyses.
Yeah, so. I mean, I guess it's just the work from Patrick Kennedy and Antonio Bertoletti, where they've done a little bit showing that there's some evidence of less exhaustion in the younger age group. But the trouble is, it's difficult to also control for age of infection.
Yeah. That was my
because
question.
it's always very difficult to distinguish for sure whether people were vertically or horizontally infected and exactly when. And I'm sure that's a really critical factor that just hasn't really been looked at properly in most immunological studies.
Yeah.
But I had a few questions while I've got the mic.
Yes, please.
Well, first of all, I was interested in the difference in relapse between the entecavir and tenofovir groups. Are there any mechanisms proposed for that? Because it was quite a striking difference.
Yeah, this is really a funny observation, and in the beginning you may think about whether it's really truth or is a myth, but I think it's confirmed in the second study. The plasma half-life time of entecavir is longer than entecavir, but this could not explain this 3 months difference. I think there are some data, and probably you are aware of that, the immunological mechanism induced by tenofovir, by nucleotide analogs, are different from nucleoside analogs. And this is my most likely explanation.
Yeah. Yeah, I mean, I thought there's some very old data from woodchucks, actually, maybe suggesting some immunological effects of entecavir. So it'd be really interesting to look at that again.
On that point, and then the duration of treatment, because some people say the duration of treatment in those entecavir studies is different from tenofovir, because we have this consolidation treatment, and then if you treat longer, you will get less likely a relapse. And a lot of people said that is actually the reason and not the difference in drugs. So what is your opinion on that?
Yeah, I think there's, of course, this could be biased and there might be confounders, and the treatment duration is one of it. Another one could be the existence of resistant associated variants associated with the lamivudine use in previous time and then entering entecavir instead of tenofovir. And from the one study I mentioned, published in Hepatology this year from Papadiodoridis, it's where they evaluated the type of relapses with respect to the level of DNA and so on. It turned out that the existence of pre-existing variants were a factor for clinical relapse. So this could go into this direction, that there might be differences. if you have already resistant variants. But nevertheless, whatever the reason is, I think it's good to keep in mind that the relapse may come at a later stage when you stop entecavir, and you can expect it quite early when you stop tenofovir, because this is confirmed in Caucasian and Asian patients.
Can I ask
go
a
on,
couple
go on.
more?
Sorry,
while I
sorry
put
to interrupt.
Harry, in the studies, in the long-term follow-up, where you show this progressive decline in S antigen, was there also progressive increase in titers of anti-S antibodies?
You mean in the ultra-long follow-up,
Yeah,
the 13
yeah.
year? We haven't tested that. I'm sorry.
Okay, and then finally, before I give up the microphone, I was really interested in your core antigen-specific B-cell analysis. Did you look and see whether the atypical fraction is different in the core and surface-specific B-cells?
Yeah, so we looked at that, but it wasn't as obvious as what you had in your papers, indeed, on the S-specific B cells.
Okay.
So, yeah.
If the duration of treatment of NUCs influences the rate of flares, respectively, if there are dangerous flares or not, because the combination study with pegylated interferon, for example, the Marcelin study with 800 patients, they all stopped after 12 months. Can you give a comment on that?
Yeah, you know, in a way, it's funny. That's where when we started with treatment, it was always a finite treatment duration. We had in the beginning, as you mentioned, 6 months treatment with lamivudine, and then it was stopped. We had the 1-year study. The landmark study, the Marcelin approval study for pegylated interferon, 3 arms, PEG alone, PEG plus lamivudine, and lamivudine alone. There was a difference in relapse and relapse-associated flares, and there were 2 patients with decompensation, if I recall right, and only in the lamivudine arm. So, well, from all the evidence we have so far, if we have a very short oral treatment, then the likelihood achieving something good in the long term is quite low. So probably all patients will relapse and require retreatment. Whether really the risk of severe flares is higher or really associated with treatment duration, I'm not sure, because you have seen it's really exceptional, very few rare cases. I think this may probably happen anyway, even if you treat for extended periods of time, but difficult to answer from all the data we have now. But that's my guess, that the risk is not much higher if you have a short period or a longer period. It probably really depends on the status the patient entered therapy and what happened during therapy. I couldn't mention all the immunological data, they are now published, but it seems that probably you can already judge from the immunological background of a patient had at the time of stopping whether he had a high risk of relapse and probably a significant flare or not. But this will not tell you whether he will lose S or not. So there are 2 different parts of the equation. On the one hand, is it risky? On the one hand, who is going to lose S?
Can I challenge you a bit, Thomas? And I mean, the stopping treatment has entered now most of the guidelines, and we're part of that, but have we not been too early with that? Because you have mortality there, right? If like 200 or 300 patients are stopped and one of them dies, that is a pretty big thing. So, and we've also seen we've done a stop study which we will present at ASLD in a few days. We saw some pretty scary flares, I must say, and there have also been other deaths reported. So what is your take on that? And obviously the problem with guidelines, as you mentioned, you state it very cautiously, but that's not always how people read it, right? They say, well, you can stop it.
Yeah, that's why I'm always with this handle a patient like being in a clinical trial. Yeah, I think this is really, I do not recommend on a general basis stopping. I think it's too early. I fully agree. I think the biggest step forward would really to exclude the 50% of patients with anyhow need retreatment. But then if it's really confirmed that you can achieve after 2 or 3 years a 20 to 30% S loss, and you exclude the 50%, so you end up with a 50% S loss in a certain population, then I think it's worth it to try. Because with all the other studies we are now aiming for cure, we also have some risks, and we do know what is the long-term safety. So in my point of view, it's only reasonable if your aim is S loss, is you probably have better predictors who has a chance for S loss, but then with a close follow-up, I think you can really prevent these significant flares, I'm quite sure, and start with non-advanced disease.
Yeah. Okay. I had one more question to both before
But,
Adam.
sorry. Yes,
Can-
I think
can I-
microphone or two, or
Can I ask one more question
Yes,
to
of
you and
course.
to?
You're the boss here.
No. Because to what extent can the stopping treatment be, both for Andre and for Thomas, stopping treatment be used as a tool for treatment designs of new compounds, and to what extent will it influence our results? Because there's a lot of drug developers here, so how can they benefit from your experience?
Well, I think what all the developers are aware, they are aiming for finite treatment. So they have to stop and they have to face these flares again. Yeah, because it will not be long-term treatment, how to follow them, how to include a flare as part of their finite concept, that they induce something with an immune modulator, with something else, with a direct antiviral, but that stopping and following a patient could be part of the treatment success. And to be honest, this was the situation with interferon. How many patients do we had with an S loss on treatment? This was followed after treatment.
No, but I mean,
You know?
specifically stopping the nukes for like 3 months and then come in with another compound,
Yes,
with a
yes.
combination of compounds. That's
You can play it in every direction, but at the end, it's all theory, and we have to study it. But of course, I think this gives you a lot to think about and to be creative in study design.
And we have to use this also then to really mechanistically try to figure out what is going on, because indeed this is, let's say, an opportunity to really figure out what the mechanisms behind the flares are, etc., and how your immune system changes accordingly.
Yeah, I mean, I'd like to elaborate on that point that Andre just made too, you know, this concept of good and bad flares. I mean, flares are not a virus-driven thing. They're an immune-mediated event, and we still don't know really those underlying mechanisms is driving that inflammation in the liver, and that's probably what we're going to need to really discriminate which of these patients that might go on to have an effective antiviral response when we get that S loss. But I did have a couple of questions, or actually one question, kind of both.
But just to answer you, I think the data have shown you that a very high HBV DNA is associated with a severe flare. Might be that also there might be some direct viral effects on the flare, whereas in those with a lower HBV DNA, it's more immune mediated. This could be something you may think about that can help to different. We know it from the transplant setting, very high levels. There might be also some viral toxic effect, let's say.
Yeah,
but
no,
sorry.
It is a good point. Yeah, because you're absolutely right. We do definitely see the highest replication. It's very stratified, I think, in the level of ALT, in how the immune system is dealing with that, whether or not that is, you know, direct cytopathic effects by the virus, which seems to be unlikely from everything we know, or some kind of trigger of the immune system there when it reaches a plateau or a threshold. I think it's a key to understanding what's happening. Yeah, so coming back, I'm happy to talk about that more as well, Thomas. But in terms of Harry and Andre about interferon, and particularly these add-on of interferon, and Harry, you kind of went through a lot of these studies. Interferon has very mixed effects on the immune response and T-cell response and K response. It's not all particularly positive. And it was kind of trickling away, but with the new therapies and interferon as the only immunomodulator, it's popping up much more for capsid inhibitors, for Mercoledex, for the NAPs. I mean, Harry, I'd like to get your impression, like moving forward, using interferon alpha in these studies. We see resurgence. Do we need something better to add on there? Andre, your kind of interpretation of how this is going to play into the immune response when we start adding it on with these new drugs that are coming down the pipeline.
Yeah, I'll answer quickly first. I fully agree with you. Interferon will be part probably of these new regimens, and we might have something better. But at least the good thing of interferon has been around for 50 years. We know how it works, and if you combine 2 or 3 newly designed experimental drugs, you don't know the interaction at all. So in that sense, interferon will have a role. I think particularly in the first coming years, once we develop more and more drugs, hopefully there might be better and other immune modulatory drugs to be combined.
In a way I agree, but I also think that it is interesting to indeed further explore what is going on now indeed with the TLRs and with the interferon lambdas, etc. I know that the interferon lambda is not used for hepatitis B anymore, but I think these alternatives for the interferons, because I think triggering your innate immune response, what interferon mostly does, that is still a very interesting concept. So the alternatives may be good to explore as well at the same time.
So, last question from the left side of the room.
Yeah, thank you. Thank you. After listening to the experts about the controversy about stopping nukes or not stopping nukes and when it's adequate or not, I just want to bring something up that may be important for this discussion, which is the recent FDA guidance for new therapies. So when they talk about virally suppressed on a nuke, potential design of studies on patients who are virally suppressed on a nuke, the agency says that alternatively, on outcome of sustained HBV DNA suppression of treatment without HBsAg clearance can be evaluated after finite treatment duration using a superiority design trial, comparing the investigational drug class and NRTI. And it says sponsors should use the following criteria for stopping the NRTI, and one it says applied equally across both treatment arms. So after listening to you today, I'm not so sure that's going to be something easy to do in a safe manner. Because I would say, the experimental arm could be penalized, statistically penalized, and keep the control arm going. I don't know if anyone's going to dare to stop the treatment so abruptly after 48 weeks of therapy, given the mix of patients are going to be potentially included in those studies. So I don't know if anyone wants to comment or anyone wants to provide any feedback.
Yeah, it's a very difficult point, and I don't know if I necessarily agree with what the FDA has written there. I haven't read it, but it is indeed a problem. What happens if you stop all the treatment, and if you stop the nukes in particular? You'll get flares, you'll get side effects basically of stopping the nukes. And are you looking at the problem? Are you looking at a problem of the stopping of the nukes, or are you looking at a potential side effect of the experimental treatment that has been given? People have said that if you stop the nuke, you should add up an additional 20% S loss just because of stopping the nuke, which you might get. So you need to get higher response rate with your experimental arm. It's very difficult to say, and I'm not completely sure whether, the FDA tries to do the best they can, but it's a highly complicated matter here.
And so, as you know, there are trials that have unequal arms, as we saw in the combination trial with PEG and tenofovir. You can have a longer treatment arm in one group, and obviously if you have predefined criteria for retreatment, I think that's really speaks to the safety of design of some of these trials. But I see we are now at our break time. I'd like to close the session and to thank my co-chair and all the speakers for their excellent presentations.